The first topic is dioptic therapy in adult amblyop from Arthur Cummings. And I think this is a very interesting and game-changing topic. Amblyopia in adults has been typically considered non-treatable, and dioptic therapy has an ambition to wipe out this paradigm. So Arthur, please go ahead.
Hi, my name is Arthur Cummings, and I'd like to share with you the remote management of amblyopia. I am chairman of the Medical Advisory Board of Binocs. So amblyopia is a condition well known to all of us in eye care, but we mightn't know that at least 300 million people are affected worldwide, and the current standard of care is patching or penalizing the good eye. And we also sort of agree that the current treatments are ineffective in adults. But this has changed completely by the introduction of dioptic therapy, specifically by Binocs. And dioptic therapy works by the following methods. When you have amblyopia, the brain simply receives the image from the dominant eye. And when you patch the dominant eye, the brain now receives images from the suppressed eye. But there's no work being done on the binocular column. When you do dioptic therapy and you look at a screen where on the good eye, the contrast is being reduced to match the quality of vision on the other eye, you now start having the brain using both eyes. And when the brain uses two images, you can have 3D vision, and you can improve the performance of your vision. So the clinical results from India in 161 subjects with a mean age of 8.2 years showed a 4 logMAR line visual acuity improvement over 30 sessions, half an hour each, and 90% developed or improved the fusion in stereopsis. And we have been able to replicate this, but with adults between the ages of 15 and 65. And you can see how stereopsis was absent, and in almost every patient we gained stereopsis, and also the improvement in best corrected acuity in the amblyopic eye. I want to share with you a case report of a 45-year-old professional photographer. This is his quote. Even when I learned about Binocs, I spoke with some ophthalmologist friends about it, and they had not heard about this treatment, and they confirmed that it was too late. It's not fixable as an adult. Man, was I excited to share the results the next time I saw them. Here is his story.
When I was diagnosed with amblyopia, they tried patching me, but unfortunately it was a little too late. So that didn't work. And then when I went to renew my driver's license, I had trouble telling what the letters were. Even though I had glasses, which were corrected to my vision, I always had trouble with the crowding. The letters just jumbled up was the best way I could explain it. At the time, because I didn't know the difference when you're just used to seeing a certain way. I'm a photographer, so I'm always been used to using my good eye, my right eye, up to the camera. So I'm used to seeing the world in a 2D way. Maybe that's one of the reasons I like using a camera and see the world that way. I've thought about that a few times, but I wonder, I have wondered if I did have both eyes working together, how that would impact the way I see the world. I've been told my whole life that there is no treatment, no cure. This is a lifelong thing. You just kind of have to deal with it. It's just what it is. You missed your window. You just have to live with it. I've heard this from different optometrists throughout the years. My wife was in the industry, also confirmed the same. We have friends who are amazing ophthalmologists who have told me the same thing. So to be honest, I had lost hope, but always hoped that something would happen one day that would give me an opportunity to try something. So she was at a conference, had a chance encounter with someone, and somehow they're working on the exact same thing without a headset. You actually just do it at home with a pair of 3D glasses for adults. amazing. And my wife tells me that my driving has improved, my distance depth perception. So that's great. So I guess she's going to credit Binox with my new and improved driving. So thanks, Binox. Maybe you can do something for my cooking as well. That'd be great. And as time progressed and as the treatments progressed, I could tell that I was improving. My brain was like really working, and it was almost like a drug. I just wanted to do it more and more, just to kind of keep feeding that muscle, exercising that muscle of the brain and of the amblyopic eye. And I mean, it was really encouraging. I'm very metrics driven. It was very encouraging. Every 2 weeks, there's an assessment with an optometrist. Everything's done online from my house and her from her house. And, you know, it was really exciting to know that, you know, in 2 weeks I was going to do an assessment and there was like some improvement. I was like, whoa, something's happening. And then 2 weeks later, you know, you feel like you're studying really hard for an exam and you're doing the exercises and you're trying really hard and there's more improvement. And they just kept improving and improving. And then I was just so grateful, especially with the depth perception, the Rand diagram. I really had a hard time with that. In the beginning, it was not detectable at all. I didn't have any score. And then eventually I started seeing stuff, actually seeing the squares that didn't exist at all. And then that improved to the point where it was beyond what the goal was. And I actually cried that day because I couldn't believe that I could actually, in the beginning, I never thought it was going to work.
So the facts of the case are that the diagnosis was that of anisometropic amblyopia. The baseline, the right eye was 20/20, the left eye 20/80 with absent stereopsis. Post Binox, the right eye was 20/20, the left eye was 20/20, and there was 100 seconds of arc stereopsis. So basically, there were 6 logMAR lines of visual improvement for distance and for near, and stereopsis gained of 100 seconds of arc. At the AECOS meeting in Antwerp in June of 2022, someone said the biggest and most exciting innovation in ophthalmology today was that of Binox. Adult amblyopes have gone from no hope to successful therapy in 6 weeks. It's the fastest and most significant permanent improvement in visual acuity, 3 to 6 lines in 6 weeks with Binox. It develops and restores 3D vision. Binox have a collaborative strategic model involving reducing eye care practitioners' clinical burden while improving revenue stream by expanding their market. And Binox is the thought leader in managing binocular vision in ophthalmology, including cataract, refractive, dry eye, and pediatrics. Thank you very much for your attention.
So thank you very much, Arthur. That was awesome. So I opened the discussion for this presentation.
Arthur, I want to make the first question. I was working with similar software from Singapore, let's say about 5 to 6 years ago, and we use it in our R&D managing director because he was amblyopic of one eye. So he was a very talented guy, very good patient, and you know, even that he gained 3 lines. So it's true that he lost this visual acuity gain after a couple of months. So it was not long lasting. It seems that this stimulus is happening, the outcomes are improving, definitely the vision improves, but it was not long lasting. So my first question to you is, how are the long-term outcomes, talking long-term, 1 year follow-up?
Right, Jorge, that's a very good question and a very appropriate question. So the answer is, fortunately with Binox, it's extremely positive. So unlike the other dichoptic therapies that are not stimulating the binocular column cells, Binox does. So the result is long-term. And in fact, to give you peace of mind, what they do is they give you a second treatment at no cost, should you ever need it at any point in time. But at this point, no one is availed of that because it's not necessary. Because it stimulates the binocular cells, and once that eye is involved in binocular vision, it doesn't degrade. So it's very different to patching, or it's very different to someone who gets a short-term benefit from refractive surgery, maybe, where the vision improves slightly. And if you don't use the eye, you lose it. But in this case, because it becomes part of your binocular system, you don't lose it. The result is permanent with Binox.
The second question is, well, we know that neuroadaptation decreases with aging. And so there's a moment which is difficult to learn. And we know that because we were learning much more when we were 8 years old than now that we are a little bit older, right? So do you have, or have you defined, or the company, any age range beyond the 30s, in which this treatment can be applied successfully?
So, Jorge, that's another very good question. So you speaking about conscious learning, learning a new language, learning a new skill set, learning music. This is not conscious learning. This is subconscious learning. And at subconscious level, there is no limit. It's limitless. And the best example you have is in the cochlear implant space. For people who've been completely deaf, they get this cochlear implant. For 6 weeks, the sound they're getting sounds like some metallic Martian speaking at them. Yet 6 weeks later, I can hold my hand over my mouth and they can hear what I'm saying with no lip reading. So neuroplasticity, we have completely underrated. And it's much, much more powerful than we think. So for this particular application, there is no age limit.
Okay, well, this is very good news. So thank you very much. Thank you.
My pleasure.
And is it on the whole European market already, or only in Ireland, or where can we get used to it, or where can we try it?
Right. So Stephanie, the company is based, I don't want to confuse the audience, but the company is currently based in Singapore, but it's not the same company that Jorge spoke about. The inventors are in India, two of them, Gul Nankani and Ali Abdullah, and they invented it. And the company that's looking after their project now, or their business now, is based in Singapore, and the European headquarters are in Barcelona. But the entire program is remote. So in fact, the example we saw in the case report I showed you, you all know the person. I don't want to mention the name. We want him to remain anonymous. But he is the partner of someone in our industry that we all know. And they live in the States. She rang me after seeing something I put on LinkedIn and said, does this really work? And I said, yeah, this really works. So she said, how do I go about doing this? I said, I'll put you in touch with a company. Everything was done remote, including the follow-up visits every 2 weeks. So it doesn't even happen in your practice. You can have it happen in your practice because for your own patients, you'd like to establish what the initial entry data is, plus the exit data, because you want to make sure that they have gained the benefit that you're after, and you want to just confirm to them that they've achieved a good result.
You know, Arthur, just going to your comment, I put a patient in a treatment, during this treatment, about 1 month ago. The patient is in Cairo, and he's following the treatment for Singapore. So doctor is in Spain, patient is in Cairo, and the treatment is delivered from Singapore. So this is modern communication. I hope that will work. It's a 26 years old young lady, you know, with one eye with hyperopic and isometropic amblyopia. And well, the vision is 0.3, so I hope it will work, you know, because it's young enough. I really think that we should have an influence of aging, you know. And 26 is perfect. It's a perfect indication. This is why I selected the patient. But yes, the treatment is available in Spain and is acceptable in cost, you know.
That's exactly right, Jorge. So the best patient anyway to start with would be someone who is quite well aligned, less than 15 prism diopter misalignment, and mostly anisometropic amblyopia. And with those patients, you basically can go in with 100% confidence you're going to succeed. The ones that are more tricky, and the company will help you with them, are those that have some misalignment and not bifocal fixation, those kinds of patients. They're a lot more difficult. But your patient you've just described should do very well, but you must give it the 6 weeks.
Okay.
Excellent. I will tell you, I'll keep you informed.
Fantastic.
Arthur, the amblyopic eye has quite often higher refraction compared to the better eye. Is there any limit in the difference in refraction in between the two eyes, or is there any absolute limit of refraction, like even for people who are -10 or +5, can you still use this program?
That's a really good question. So the key thing is not really the anisometropia or the exact refraction, but it's rather what the best corrected vision is in that eye. And as long as the best corrected vision in the amblyopic eye is at the 2200 or the 660 or the 0.1 mark, then you have a very, very good opportunity to gain at least 5 lines and establish and maybe even develop stereopsis.
Okay, so you kind of decrease the quality of the picture in front of the better eye to be able to blend both pictures separated by red and blue spectacles, and then the brain is forced to connect the pictures together. That improves the vision of the lazy eye and also the binocular function.
Exactly right. And the second part of this thing, that when you look at, if you read anything in the literature about neuroplasticity, you'll see one of the things you need to initiate it is you have to have a will. There has to be an additional drive why you want it to work. So all the games that you're playing need binocular vision to go to the next level. So that's the drive subconsciously. You want to get to the next level, so you want to see binocularly. And in a way, you know, when you speak to colleagues about this, many will say, no, it can't be, it's impossible, it can't happen. So for many, it's a paradigm shift that's just too far. So the way we explain it to colleagues now when we're trying to get them involved, because it's a game changer, as you said earlier, is we tell them it's not so different from regular patching. And what do we mean by that? So we say, well, the first thing is, instead of patching the eye completely, we're going to simply centrally suppress the contrast in the dominant eye. And then instead of, in the good eye, and then instead of patching the other eye, we're going to keep it open. So it's two small little changes. And most people there aren't too disturbed by that, because they realize the amblyopic patient is using the good eye and ignoring the other eye. So they're not too bothered by the fact that, I don't know if I'm saying it right, but what I want to say to you is that we're trying to explain to people that it's not such a paradigm shift, because anyone who's treating children or the regular patching just thinks this is a step too far. And that's why the company decided to try and change the mindset of pediatric ophthalmologists. It's too difficult. It's better to go to a place that's always been regarded as impossible to treat. It's blue ocean. And the results we're seeing in adults is spectacular. I can't wait to hear what Jorge says to us in 4 weeks' time.
Perfect. Congratulations. Really something highly innovative. We are looking forward to that.
Thank you very much.
Mm-hmm.